sorry, this is my new center. So we are Clatterbridge in Wirral, where the Papillon Center was originally. And then when the new cancer center was built in Liverpool, as you can see in this picture, the Papillon unit has to move to that. And we now do the treatment in theater, alternate with when they're not operating, because we also do HDR brachytherapy as well as an alternative. But I'm not going to talk about HDR brachytherapy. So I have no conflict of interest to declare. And for those surgeons who are in the audience and the oncologists, the standard of care for rectal cancer, either they are good, which is early stage tumors with no lymph nodes, or very bad tumors with lots of lymph nodes and involve mesorectal fascia. And there's a middle group where the mesorectal fascia is clear, but they have got some lymph nodes, but the margins are all negative. So only for the last group, the ugly group with a very advanced tumors with lots of lymph nodes, but more important, the mesorectal fascia is involved, as in this case, there is a role for preoperative chemoradiotherapy to downstage the tumor, to move this tumor away from the mesorectal fascia, and then they do surgery. For the first two groups, the good and the bad, there's no role for radiotherapy. That is the standard of care in UK, and I'm sure it's the same in Europe and elsewhere. And I'm sure in Switzerland you follow the same pattern, and we can discuss about that later. And most of the time, when the patients are diagnosed, we discuss these in a multidisciplinary team meeting, which is what you were doing earlier, I believe. And then you show the histology, you look at the imaging, and then you make the recommendation for this particular treatment. And the recommendation that are made are based on the national and international protocols, the national and international guidelines, and all the published evidence. And that's what traditionally people do. In these, there's no consideration for patient's choice or wishes. And organ preservation is not on the agenda for any of these protocols or guidelines at the moment. I'd like to take you to one of our patients who was a 79-year-old gentleman who comes to Switzerland regularly to do skiing, and he's very fond of that. He was 79, he was a retired lecturer. He comes once or twice a year, he goes to France sometimes, comes to Switzerland. And then he was diagnosed with rectal cancer towards the end of 2008. And then these are the endoscopic appearance of his tumor. And then he had a staging MRI scan, which shows the tumor is quite low in the rectum. We discussed this in the MDT, and there were lots of lymph nodes. It was an N2 stage. So I've offered him chemoradiotherapy. And then 8 weeks later, we did another MRI scan, restaging MRI scan. At that point, the advanced tumor almost disappeared. The radiologist couldn't see any tumor. So the young surgeon said, he's coming this afternoon. I'm going to talk to him, and we'll do surgery for him. So I went for my lunch, and the surgeon came to lunch with me. And after he's seen the patient after the lunch, he rang me to say, Sunny, this man doesn't want to have surgery. He wants to go skiing. He's got a skiing book next week. So I said, have you actually scoped him? And he said, no, I haven't scoped him. So I said, come on, let's scope him and see what happens. So when we actually scoped him, you can't actually see any tumor, but you can feel a little bit of induration beneath that. And I said, there is a residual tumor, you've got to do something about it. So I said to the patient, okay, if you don't want to have surgery, you go skiing next week. And when you come back in 2 weeks' time, come to me, I'm going to do some treatment with Papillon. And he said, so long as I don't have surgery or stoma, I'll do anything. So he went skiing and he was happy. I was happy because he's coming to have some treatment with me. So the dilemma for clinician is that when some of these older patients who are medically fit, he goes skiing regularly, But when they refuse surgery, we don't know what to do, because the MDD decision was go for surgery, and patients saying, no, I don't want surgery. So what do you do with that? Because the gold standard is to have surgery, and MDD has said that you must have surgery. So this is a dilemma that we face. So to give you the background, I've told you that the standard of care for rectal cancer is surgery, and we all agree with that, and I respect that. But if you think of the morbidity and mortality, the surgical mortality and mortality increases with age, and I show you some evidence on that. And then if you look at the age of the rectal cancer, majority in United Kingdom, and I'm sure that it's similar in Europe, they are above the age of 65, which is a geriatric age, you know. And then for patients, quality of life, surviving beyond cancer, treatment is important. And we're beginning to realize that now. And obviously that's the reason why you invited me to speak on this. So you are interested in that. So therefore we should personalize their treatment and not do one treatment that fits all. One size fits all is not an option for rectal cancer treatment. Why do we want to personalize it? Because there's an increase in aging population. I'll show you some evidence of that. And there's a recognition of harm from major surgery, especially in elderly, the second point. And thirdly, we have national bowel cancer screening program now. In UK, been going on since 2006, so last 14 years or so. And I'm sure you do the same in Switzerland, bowel screening. This is a gentleman who had a rectal polyp removed when he was 99. And then unexpectedly, that polyp contained a focus of cancer. So the surgeon came to me and said, Sunny, I've removed this. I thought it was a benign polyp, and I just do a local excision. And there was a focus of cancer. The standard of care is to offer him AP resection. It's very low tumor. I don't want to do that. He's 99. So I said, no, don't worry. I will do some treatment for him. So I gave him 2 shots of Papillon on the scar, and he became 100. When he became 100, traditionally in UK, we get the telegram from the Queen to congratulate them, you know, reaching 100. Poor Duke of Edinburgh didn't quite reach it. You know, it was 8 weeks short of his 100th birthday. He passed away. But the Queen normally gives telegrams, as we call it, for these people who reach the centurion. And then I said to the patient, I've never seen this telegram. Can you bring it in? So yeah, I will. So he brought the telegram, and I said, can I take a picture of that? So he said, fine, you can take a picture. So as I was leaning down to take a picture, he said, Dr. Myint, she actually didn't sign it, you know. So it was electronic signature. So our Queen was a very hardworking lady since she became Queen over 60 years ago. She would sign all these by her own fair hand. She always writes in pen, you see. And she said, no, this is electronic. So that really struck me. And that brings home the reality that patients are getting older and older. Before she became, when she became Queen 60 years ago, you know, this is the data, the European data. If you look at the age 80 plus, the dark blues are the age, the proportion of patients who are 80 plus in 2008. And the light blues are the one predicted in 2060. And you can see that 80 plus were 22 million in 2008, and that will triple in 2060. So the aging population is expanding in all continents, you know, in Western countries. UK data is exactly the same, and there is data from the surgical mortality and morbidity. This is the chart from a surgeon called Simon Bach from Birmingham. Some of you may know him. And this is a radical surgery, age between 75 to 84, for very early stage tumor, T1, T2. And when they have a proportion of patients who died, 1 in 5, morbidity almost half. And that's too much, you know. And usually these patients who are grossly overweight, they've got lots of comorbidities, or if they're very frail for their age, that is something that you need to bear in mind. And then through the National Bowel Cancer Screening Program, the prediction was that we will see a lot of early stage tumors. And about a quarter of them, we would expect them to be polyp cancers, which are very suitable for local treatment, including Papillon. This is no longer a dream. It's a reality now. This is our data from Northwest, shared by Professor O'Toole from Liverpool University. And we're seeing a lot of the early polyp tumors being diagnosed. Sad thing is, this is the variation in APR across the NHS trusts. Some trusts are giving AB resection on 50% of cases. Some are doing less than 20%. But sad thing is, a lot of these cancers were Jukes A cancers having AB resection. 32% of Jukes A end up with the permanent stoma. And there is something not right here. So there's a publication by Professor Morris' team. She's now in Oxford. Time to intervene, she said. And that was published over 12 years ago. And still nobody's intervening anything. All the early tumors are having over-treatment with AP resection. Some people are prepared to die. They don't want a stoma. And some with this sort of medical comorbidity, rheumatoid hands, how can they cope with the stoma? And there are young or old, they say that I don't want surgery, although your computer is saying there is surgery, although MDT is saying surgery, I don't want your surgery. There are people who are refusing to have surgery. So it's a balance, and it's a very fine balance of what you gain versus what you lose. But for surgeons, we have to follow the guidelines. Even for small tumors, you have to do major surgery to achieve a cure. But the price the patient have to pay is too much, and patients are saying, no, I don't want that. So what do you do? My inspiration came from this book by Professor Papillon, and we call it Papillon Technique to honor him, really. And the family was so grateful for that. But this is Chris Marks, some of you may know Professor Marks, who actually wrote and helped Papillon to write this book. And this is my Bible. I went to Lyon to see Professor Papillon, but he was nearly 80 at that time. Papillon said to me, I don't do practical treatment. You go and see my protege, Jean-Pierre Jarad, who I still work with. He was in Lyon, and he's now moved to Nice. And I led the team. My professor said, Sunny, we don't have this facility here. You have to set it up in UK. Take a team, physicist and radiographer, and I went to Lyon to learn this. And then when I came back, we don't have a machine. And this was a machine made by Ariane Company, because the initial machine that Papillon was using is Philips machine. The Philips don't make these 50 kV X-rays anymore, and they go into diagnostic and all. So it was a British company that made this machine. So when this machine was made, the managers, as usual, oh, we don't have money, we don't have money. So I said, okay, I raised some money through the charity events. It's not a lot of money, 100K. I managed to raise that with 2 charity events, and I managed to buy that machine. How this Papillon is applied is directly onto the tumor. It's a very low energy, 50 kV X-ray. It's like a dental X-ray, but you're applying a very high dose of radiation, 30 gray per fraction. Each of them, EQD equivalent is 100. So we do it every 2 weeks. So total of 90 gray. That's equivalent to about 300 EQD, which is a very, very high dose, 5 times more than what you normally do with external beam. But you don't see a lot of collateral damage because it's a tumor is targeted directly on the high dose is applied directly to the tumor, very little collateral damage, and therefore it has very little side effects. I'll take you through this quickly. This is a big polyp cancer. You can see my cartoon there, muscularis mucosa, muscularis propria. It's a T1 tumor. A lot of these end up with the AP resection. And Papillon said, no, you don't need that. I will treat it with Contact. And when this patient came on the day 1, this is what it looks like through the applicator. After 1 fraction of contact radiation, the tumor shrinks down, and you can see not a lot of normal tissues there. And this is my cartoon there showing shrinkage in all directions. And then second treatment is applied. After second treatment, there's no tumor left. And initially, when I came back, I couldn't believe that. So we were doing local excision to find out what's left there. And there was no residual tumor left. And this lady lived for over nearly 8 years. And then she was in her 90s and she died away. But this is a sort of tumor that has responded well to treatment. This is the position that we're using now. There used to be Nietzsche's position. In my videos, you will see that. But now we treat them in the lithotomy position, which is much more convenient. So for those radiotherapists in the audience, I don't want to go through too much with this, but we applied the dose on the surface, that 30 gray. The mucosa, it went through the mucosa where the muscle is, muscularis propria is about 5 millimeter thickness. So this is very suitable for either T1 going through just muscularis mucosa or going into the muscularis propria. So this is the physics part of it. So I'm going to skip this quickly. When patients respond very well, when there's no residual tumor, we just do what we call watch and wait and no surgery. When there's small residual tumor and surgeons in the audience, you can do local excision on these. And most of the time, there's no residual tumor pathologically. But if there is a residual left, this is the TIS or T1A. So that is an option. But obviously, if they don't respond, and very few don't respond, I would say, more than 80% respond to treatment, then they can have the normal surgery. And we're doing a trial, which I'll share you in a minute. There are side effects, of course. You get what we call radiation ulcer. So where the tumor was, you can see a superficial ulcer. When you run your finger over it, it's quite soft, superficial, and you can't feel anything underneath. And that sort of ulceration heals after about 3 to 6 months, and sometimes a bit longer. The second side effect is bleeding, which can be troublesome because you get a telangiectasia around the scar. And then 10% of patients, usually these are patients who are on anticoagulants or clopidogrel, they tend to bleed more, and we need to do argon beam to try and treat these blood vessels, and that controls it very nicely. NICE, which is our governing body, has actually looked at it, side effects, and then they have published guidelines in 2015 to say that this is a safe treatment for patients who are not suitable for surgery. This is the world data that needs updating, but I use this slide in memory of Papillon, and he was the first person who shown in his cohort that local control is very high. And this is Jean-Pierre Jarrat in his earlier cohort, similar sort of control. Professor Seshi is from the United States. They went and they have lots of treatment in the United States. And local control is quite high. And this is my data, nearly 90% when I first published that in 2007. Since then, I published 2 more long-term data, 2003 to 2012, on 200 patients. The complete clinical response is about 70%. And then of those who achieve a complete response, 11% had a regrowth, and most of these patients are salvaged. And complete clinical response is maintained in majority of these patients. There's a second publication in the Red Journal, and these are the references, and you can look at these. But the Red Journal is very specific. The 200 patients got all stages. The way we treat is all quite different. And they said, we want everybody who had external beam chemoradiation. We don't want any short courses, and you must do the Papillon 4 weeks later. So we select out 83 patients who had very consistent chemoradiation 4 to 6 weeks later Papillon. And this is the cohort. And again, the results are very similar. 60+% responded. Local regrowth is 13%, and majority of these have salvage surgery. Now, there was interested in non-operative treatment, and we have to give credit to Professor Angelita Habagama. She's now in her 90th year, or approaching 90th year, and she published the data first in 2004, and it's like a bomb thrown down, in the surgical community. She was saying, surgeons don't operate. If the tumor goes away, just wait and see. And this is the update she published 10 years later. What she was saying was, if there's a tumor there, you give chemoradiation. If there's a residual tumor, you go for surgery. The patient go for surgery. But if this tumor disappeared, and this is what she called clinical complete response, and if it is sustained 6 months to a year or 2 years later, don't operate. Let's just wait and see what happens. So she was saying exactly what I alluded earlier. You tailor the treatment according to the patient. And this is something that I didn't know when I was doing the Papillon. I only met her about 10 years ago. I was doing this for nearly 30 years now. Then what she was saying was, if there's a residual tumor, you go for surgery. If there's only a small residual tumor, you can do local excision. And this is exactly what I was doing with my patient. When there's nothing left, don't do anything. And this is just with external beam. She always teased me, Sunny, you don't need Papillon. We can do it all with external beam. And there was a consensus meeting. Some of you may know Professor Bill Heel, who's a doyen of the surgeons. He's now retired. He's a bit younger than Angelita, but he was the one, both of them were quite instrumental in this international consensus meeting. The first one was in 2014. We had one last year, actually, another one. So there were quite a few. And then there were publications on the consensus. But this concept is not new. We have seen this with anal cancer. Professor Nigro is my hero. And he was also a surgeon. And he said, chaps, don't do surgery on anal cancer, because they were doing surgery on all sorts of anal cancer. And when they can't operate, the Americans offer patients chemoradiation, and then they still do AP resection. And when he looked at that, his aunt had anal cancer, and his aunt said to Professor Nigro, Norman, you're not going to do AP on me. I will have chemoradiation first and see what happens. And sure enough, the tumor disappeared. And he said he realized that they were over-treating patients, so he stopped doing it. And this has become, chemoradiation has become standard of care throughout the world. And this will be a scenario for rectal cancer as well. So these are the data, comparative data from Alpha Gamma, initial 183 cohort, complete response nearly 50 once she intensified the treatment, but regrowth, after achieving complete response, the tumor grows back. There was a Danish data giving external beam chemoradiation 60 gray, and then they have HDR, brachytherapy. So the initial complete response is very high, but there's still a local regrowth of about 26%. Andrew Reinahan is a professor from Christie I work with closely. This is the British data. All the publications are in here. You'll be able to look at these. Again, this is a chemoradiation on its own. Local regrowth is quite high, nearly 40%. And this is my data you've seen published in British Journal of Radiology. My initial complete response is 70%, much higher than with external beam alone. And the local regrowth is much lower. So that's my data. And the Danish group wants to look at this and see why is this that the Papillon works so much better. So if you increase the dose, the response rate gets better. So standard treatment is 55 maximum most people would give. And then you get the response in about 30+%. But when you crank the dose up to 90+, 45 gray, then the response rate is much higher. And that's how this curve explains why Papillon works so much better. Coming back to my gentleman, what does all this mean? So there is a group from Royal Marsden, this is the Mercury group, looking at if they have good response to MRI, the disease-free survival is much better, but a lot of these patients end up having surgery. And when there's little or no residual tumor, the long-term outcome is much better than those who don't respond. So there is some meaning in it. But we do need evidence, and we're doing a trial called OPERA, which I share my data in earlier, which Daniel is mentioning. So it's 2-arm study for not early stage T2, T3, A and B with some lymph nodes less than 5 centimeter. arm A is the standard of care, chemoradiation with external beam boost, 45 gray and 25 fraction with the 9 gray boost, bringing to 54 gray. Compared to external beam chemoradiation, same 45 and 25 with the Papillon boost of 90 gray. So 9 gray external beam versus 90 gray Papillon. And we assess them at 3 months. And then if there is still a residual tumor, we continue watching another 6 weeks. And then at 6 months, we have to make a decision. If there's no tumor left, we do a watch and wait. If there's small residual, then we can do local excision. If they don't respond, they go for surgery. So this is the data I'll share, which I presented, and it's coming at the ASCO, which was presented. So 148 patients, 142 evaluable, 71 in each arm. So about 30% needed surgery, either for residual disease or for regrowth. And 19% needed major surgery. And a lot of them had local excisions. So conclusion of that abstract is over 80% organ preservation was achieved without compromising their chance of cure. The main paper will be published between the 2 arms. This is for overall both groups, that organ preservation is feasible. But for each group, the main data will be published in 2 years' time. So watch this space. So we are planning another trial called OPERA 2, 2 meaning 10 surgery, watch and wait, or contact. So it's going to be a 3-arm study. So patients who had external beam and the small residual tumor, we will just continue watching them after 3 months, because most people, Habagama and other people, will say, oh, this will just go away, don't worry about it. 3 months later, 6 months later, tumor will go away. Our group will say we need Papillon at 12, 14 weeks, because that will improve the local control, which the data I've shown. All the surgeons will say, oh, no, we don't need Papillon. We can just do local excision and see what happens. So we're doing the trial design at the moment in discussion. And that's the next trial that we're doing, because OPERA is finished now last year. So this is a new trial. Hopefully that will be next year. We have got the funding from H2020. So the whole program, they got about 6.5 million. It's the active monitoring of cancer as an alternative to surgery. So I think that quite a lot of European groups are in it. I know Britain is not in EU now, but the EU still holds this because the award was given in 2018. So I will have 2 PhD students starting from May, and they will be with me for 3 years, funded by EU. And we will see a lot of the data from these 2 PhD students. NICE has approved Papillon in 2015 for patients who are not suitable for surgery. So when the OPERA results comes out, OPERA is all for very fit patient refusing surgery. But if they have to have surgery, they will all have surgery. And this is the data I just showed you. There is a video of those who are interested. Go into Clatterbridge Cancer Centre website, and you'll be able to see that. And the number, when I started, I only got 1 patient. Gradually, after publishing a lot of these data, and when the NICE guidance was published, the numbers have since gone up significantly. We've now got, these are the referrals that come from all over the country. And we have patients from all over the world, some from Australia, Europe, United States, India, and Burma. And we've now got 4 centers, 1 in Hull. This is a gentleman from Hull. We've now got the 3rd center in Nottingham and the 4th one in Guildford. So we're waiting for the specialist commissioner to do this trial, and hopefully we will be able to get more centers. Around Europe, we have 15 centers. So I will tell you a story of a young male, 31-year-old, quite young. I've told you extreme age, nearly 80. This is the extreme age of 31. He had a low rectal cancer. He was diagnosed with rectal cancer, and he was told that he needs chemoradiation, which was happy to, but then the surgeon said, you need to have an AP resection, your tumor is too low. So he wasn't happy, so he requested the second opinion. That was what his tumor looks like, with some ulceration there. And when he came up, he was told that he needed chemoradiation and AP resection. So he came up to see us to see whether there are any alternatives. And I said to him, no, you're not suitable. This is a too big tumor. I can't do that. He said, no, I'm going for chemoradiation tomorrow in Bath, St. Bartholomew Hospital. Will you see me again? I said, normally you go for surgery. I don't see patients again. No, please, because if I go for surgery, it would mean a permanent back. I don't want that. So we decided to see him. And when he came back, there was hardly any tumor there. Like the old gentleman, when you feel it, you can feel something underneath. So I gave him 2 shots of Papillon. And then we weren't sure at that time what was happening. So he had TEMS resection of the scar area. This is the surgeon, Mike Hirschman, who I worked with closely at that time, but he's retired now. So he's removed that area. And what he looked like is quite a big area where the residual induration was. And you can see the thickness. It's gone through the mesorectal fat. You can see that quite clearly. And when they look at the histology, you can see the ulcer, pool of mucin, but no residual tumor. That's the muscularis, the 2 muscles there. And then just the perirectal fat and no residual tumor. And the surgeons then said, oh, this will come back. He's a young guy. He will have metastatic disease and he'll be dead in no time. So Mr. Hirschman left the hospital at that time. The other surgeons took over and they were doing EUA every year. After 3 years, they said, he will be cured. So I said, I don't know whether he's cured or not. I carry on seeing him, which I did. And he's now 18 years out and he's still alive and well. And he wrote a book called Saving My Ass. And you can read that. You can go it on, Google it, and then you can get that book. This is a guy who wrote that book. And he's now advocate for patient's choice, living beyond cancer. So when the tumor disappeared like that, I'm going to show you another 91-year-old gentleman. You don't need AP resection. This gentleman is dead now, and he died 2-3 years after this treatment. He had a heart attack and died. And then if you're going to have an AP resection, that's just wasted. He will die with the stoma. He doesn't need that. Now I will tell you another story. This comes from Netherlands. A young guy, that's a singer. With his permission, I'm showing the pictures. He said, you can show the world what we are. He's a singer, entertainer, beautiful wife, bleeding, and he went to have an endoscopy, and this is what the tumor looks like. And the surgeon at that time, Professor Rutten, some of you may know, persuaded him to go for AP resection, and this is going to cure your cancer. So he actually agreed to it. So while he was doing the EUA, Rutten noticed that this is a very mobile tumor, and it's more likely to be T1. And this is the MRI appearance, and you can see it. They can't tell whether it's a T1 or T2 because it was reported as T2. But when he was examining, it was freely mobile. And Ham rang me to say, Sunny, would you do contact on this guy? So I said, yeah, of course I will. So after 1 shot of contact, the tumor shrinks down. After second shot, there was nothing left. So these are the years. He's coming on to almost 4 years now in January when he finished. And he developed an ulcer. And then that's all healing nicely. I just spoke to him about 2-3 weeks ago. He's still fine and no evidence. So if the options are back for life or death, what will the patients choose? But we need to look in the future and think outside the box. Because of our training, the governance, the guidelines and protocol, we go for the standard of care, and that's what the MDT tells you, and nobody dares to go against that. But you've got to think outside the box because there's a change in disease stage. You're picking up a lot of early stage tumors, not like advanced stage. Advances in science, advances in technology, new innovation, new concepts. You need to try and change the mindset and think of the patients and what they choose. So this is a team, our team, who won the British Medical Journal Award in 2018. And we've got all 4 centers here, and that coincides with that 25 years of Papillon in Clatterbridge. Winston Churchill will say, success is not final, failure is not fatal, it is the courage to continue that counts. We got a date for your diary, 1st of September. We're going to have a meeting, multidisciplinary management of early rectal cancer. Hopefully by then we don't have to clamp down now. And then if you can come. If you can't, then you can join in by like we're doing now to attend that. So that will be an interesting meeting. In conclusion, I would like you to consider organ preservation for early rectal cancer, especially in elderly or patients who are not suitable for surgery. Consider entering patients who are fit into clinical trials. We've got OPERA-2 coming. Consider organ preservation for advanced cancer, like the first patient I showed you, when they're downstage after external beam chemoradiotherapy or short course. Any residual tumor regrowth can be salvaged successfully, which I've shown you with my ASCO abstract presentation. I would make a plea to you to give choice to the patient in shared decision-making when you're doing consent for their treatment. And take-home message I would say is allow patients to choose the treatment option that suits them best. We don't know what they want, we don't know what they can put up with. I want you to consider watch and wait after external beam as an option for either patients who are not suitable or those who are refusing surgery. Remember, most patients do not want stoma if they have a choice. I thank you for your attention.